Awesome. Well, let's get started. Happy Thursday and happy summer to everyone. And thank you for joining us today for our webinar, which is titled Making Sense of Behavioral Health Measurement. Please note that today's session will be recorded, and so you can push the button that says OK on your screen. So today we're going to build on insights from our recently released Partnering for Impact guide and our new paper, Making Sense of Behavioral Health Measures. It's a paper that explores the current landscape of behavioral health metrics. We will learn how organizations can continue to drive better long-term outcomes aligned with payment and identify opportunities for further work and exploration to continue to improve quality and outcomes. So we're pleased to have three great speakers joining us today. We've got Josh Rubin, Vice President of Client Solutions from Health Management Associates. We've got Crissie Anderson, who serves as the Executive Director of Quality, Compliance, and Data at Lutheran Social Services of Illinois. And we have Kate Hutchinson, who serves as Deputy Director of Lutheran Social Services of Northern California. So feel free to use the chat to introduce yourself. We always like to get a sense of who is in the Zoom room and submit questions through the webinar via the chat as well. We'll incorporate those throughout the discussion. So now I'm pleased to turn it over to Sarah Dobson, who will get us started. Thank you, Sarah.
Thank you. Thanks everyone for being here. As Alicia said, we want this to be an interactive session, so please feel free to enter questions, comments in the chat box at any time. But before we formally begin, as usual, we'd like to ask you to submit answers to a poll that help us gauge how everyone is learning and gaining information from our poll. Hopefully you're seeing that there on your screen. And it's a one-question poll. How would you rate your current level of understanding of behavioral health measurement tools and how to use them? So we'll let that percolate for a moment. And when we hit stop, I'll share that poll data. And then I'll share a very brief overview of what we're seeing on the Hill and here in Washington right now. Okay. So far we've got a pretty good bell curve there. 11% at very low understanding, 22% limited, and then 33% at moderate. So our goal is to help folks move from those buckets up into strong and very strong understanding, so you're able to use this information and integrate it into your work. So with that, I'd like to share a little bit about what we're seeing happening here in Washington right now. And a lot of this is in our advocacy work. We're really focused right now on moving that through the lens of our Here We Stand campaign. That's our integrated national messaging campaign, focused a lot around Medicaid and preserving and protecting Medicaid and sharing the strengths of our network as they work in these areas and working to address concerns about the implementation of HR 1 and the funding cuts and program integrity changes and eligibility changes coming from that. We're also really eager to hear from you what's happening on the ground and sharing with us stories of impact and how that's affecting your work, the people that you work with and serve, and stories of impact on the ground that we can use in our advocacy with federal stakeholders and lawmakers. And we also continue to urge you to take action. We have a great resource of all of our messaging materials, template, op-ed, and letter to the editor, FAQ to help you as you're having these conversations with stakeholders or people who may not be as informed on these issues as you are. And this is especially important given that we anticipate Budget Reconciliation 3.0. This is another piece of large legislation that we expect to be coming through Congress. We're hearing different timelines, and it kind of depends on how quickly the House and Senate leadership can coalesce around what will be contained in this package. But it's a similar procedural mechanism as the first bill that had the Medicaid funding cuts, and we anticipate there will be additional cuts and changes in this bill. So we urge you to take action with us in our messaging and communications campaign, in our advocacy alert that we have on our website, and in media engagement. And just wanted to share a couple of great examples that we've had of that among the members. Jason Kronk of Emmanuel Living in Montana was recently a guest columnist for the Flathead Beacon, and he had a column highlighting his concerns related to funding cutbacks for Medicaid in their state. In Nebraska, Chris Tonnegas, who's the president and CEO of Lutheran Family Services, spoke with Nebraska TV about his state's implementation of Medicaid work requirements and the impact on their providers and communities they serve. So we really encourage you to take a look at those. I think Kylie's sharing those links in the chat, and that'll be in our follow-up materials. But it's a great example of how we can support you. And this is something our team is happy to talk to you about, or your communications folks, and work with you to do this kind of great engagement and media outreach in your state and district. And just quickly on a couple of other pieces, in other Medicaid news, we're watching a recently published interim final rule from CMS on the work reporting requirements, which were part of HR 1. These are steadily being rolled out in the various states. We're especially watching the medical frailty provisions. And given the differences by state, we're tracking that, and we'll share updates as events unfold. Nebraska has been the first state to put these out, so that's especially why we've been watching there, but other states are having to publish theirs as well. And then there's also been some proposed changes to the 1115 waivers under CMS, and briefly this would say that states would have to submit actuarial or other form of rigorous analysis to show financial impact of their demonstration activities. In other words, if they increase federal Medicaid expenditures, they wouldn't be allowed to move forward. And this would really drastically have the potential to change those waivers and how they're used. So we're tracking this, and we'll be sharing more as we learn more about how this may be implemented going forward. We also wanted to make sure you were aware of an Office of Management and Budget proposal to make sweeping changes in the federal grants system. This would mean agencies could terminate or suspend discretionary grants without cause, including adding new terms mid-performance, and withhold funds indefinitely if the grants don't align with administration priorities. There's some potential for not offering funds if they don't align with the subject matter that the administration has said is approved. And there's a risk of even nonprofits not wanting to apply for the federal funding altogether, causing major disruptions to housing, healthcare, and food security in local areas. We're sharing, and we have shared in our Capitol Communications newsletter, a tool to help you comment to your members of Congress on this issue and share your thoughts about how this might impact your work. And finally, on the housing front, we are closely watching the 21st Century Road to Housing Act, which has been bouncing back and forth between a House version, a Senate version, and passage in each chamber. This week, we are learning that the Senate has negotiated with the House to have a final version of this. They are expected to vote on that, or maybe even are doing that today. And the House will be back next week in session, and the hope is that they will return and vote on that bill, and it will be passed and become law. So with that, I'm happy to turn it over to Sue Polis to introduce our first speaker.
Thank you so much, Sarah. And it's wonderful to have everyone with us today for this important conversation on making sense of behavioral health measurement. We've had the pleasure of working with our speaker, Josh Rubin from HMA Levitt over the past year, who's been engaged with us in our work related to the Strengthening Families Initiative, and who has really just been with us when asked, right, including with our Policy and Advocacy Committee most recently earlier this year around this seminal discussion around behavioral health. So it's just a pleasure and honor to hand it over to Josh to let him tell you some great insights related to making sense of behavioral health measurement. Josh.
Thank you, Sue, and thanks everybody for being here. It is always a pleasure to be with Lutheran Services in America. Um, I'm a consultant, so I have slides. I apologize. I kind of can't help myself, but I promise to be quick about it. You know, the issue we have in the behavioral health side of the world is not that we don't have enough performance measures. The problem is we have way too many performance measures, and we have not all agreed what the important ones are. Um, if your primary care doctor tells you that your diabetes is becoming a problem, there is one performance measure that everybody involved is going to track: hemoglobin A1C. And everybody knows what the standard is, where it's too high, when it's in remission. There is universal agreement about what should be measured and how it should be used. On the behavioral health side of the world, we have all of these different measure sets, including some with government, federal government imprimaturs on them, but we have lots of measurement sets that have been proposed by lots of different places, including some of the accrediting organizations, and then, of course, NCQA, which creates HEDIS, which is how managed care organizations are measured, has a whole other set of measures that are related to behavioral health. A lot of those are frankly measures of convenience. We measure them because we can, not because we think they're particularly important. But ultimately, the issue is that we see is all of these folks have not reached an agreement on, like, what are the core measures that we should be looking at, and how do we all agree? What do we all agree is important? When I am talking to groups around the country, I tend to fixate on two performance measures because they're very clear, they're very bright line, and they're very easy to track: suicide rate and overdose rate, overdose death rate, I should say, right? Those are not ideal measures, again, but they're measures that we can keep track of, and they are measures that do give us some sort of a sense of the temperature of the service delivery system. But as you can see, even when you just look at the sort of the behavioral health core measure set, the CCBHC measure set, and what NCQA has identified, there is not agreement across all of those in the process side of the house, in the outcome side of the house, or in the structure side of the house. And heaven help you if you're trying to get everybody to agree on what constitutes network adequacy for behavioral health care, because there is no consensus at all about what constitutes a sort of an adequate network for behavioral health care. All of the issues there are very vague. Because of that, I think a lot of community providers get sort of stuck flat-footed. If I don't know exactly what to measure, I shouldn't measure anything. And there is a real sense that I see over and over again of the perfect being the enemy of the good, and of the sense that because there aren't three things that everybody agrees I should be measuring, I'm just going to stick my head in the sand and sort of hope that everything goes away. And ultimately, part of the challenge here is that with respect to behavioral health care, not everything that providers do is easily measurable. It's hard to measure whether or not people are feeling like they're being treated with respect and dignity. It's hard to measure whether a therapeutic alliance has been developed between a clinician and a client. And so it is more complicated than some of the measures that you just take a blood test and then you know. But at the same time, the key from my mind is that you got to do it anyway. Right. And I say to my clients a lot, a journey of 1,000 metrics begins with a single measure. Right. And the key is, wherever you are, take the next step, right? The first step, I think, is to agree on why, right? Like, you and your team and your organization need to sort of agree. What are we to what end are we measuring our performance? Let's get some clarity about who we're measuring, what we're measuring, why we're measuring, and then let's make sure that we have aligned it with our workflows so that everything is happening in a way which is methodical, rigorous, organized, and as burdenless on our staff as possible. In that context, clear roles for who's on the team. Push it down as far as you can. Allow your clinicians to operate as close to the top of their license as possible, but ultimately, just do it. Start with a de minimis set of measures. Start with one, if just one. And a lot of times, the first one that people start with is that sort of follow up after hospitalization. Are we seeing people within 7 days of a discharge from a hospital or an emergency department? Personally, I hate that measure. If I've been in a hospital for a psychiatric illness, and 6 days after discharge, you give me a call, you got the measure right, but you didn't provide the quality of care that people really need and really deserve. Critically, any of this stuff, do it with your staff, not to them. Staff frequently perceive that the purpose of measurement is punitive. Make sure they understand that the purpose of measurement is quality. You are doing this with them to improve the quality of the care that they are able to provide to the people that you all serve together. You are not doing this to them, and that is critical for getting the staff to buy in to why this is happening and what's happening, and ultimately actionability. Right? There are so many things you could measure because they would be interesting. Don't measure anything because it's interesting. Measure things because you can do something about it. The purpose of the measurement is not to have measures. The purpose of the measurement is to use those data to improve the quality of the care that you're able to provide. Ultimately, none of this is easy, right? There is a simple reality. This stuff is complicated. This stuff is messy. This stuff is generally not compensated. This stuff is not standardized. A lot of organizations that I work with have multiple sources of truth, different databases scattered around their organizations. And ultimately, the key is to connect it to the work that you do, because although it is not easy, it is absolutely essential, especially in this moment in history. First of all and foremost, you have an opportunity to improve the quality of the care that you offer. That opportunity is too good to pass up. Do not sleep on the difference good performance measurement practice can make to the outcomes of the people that you serve. Your staff deserve feedback, right? At a certain point, feedback is love. You are investing in your staff. You care about them enough to provide them with the feedback. And ultimately, not so much today, but in the system that we're moving towards, with sort of more value-based payments, what gets measured is what gets paid for. And ultimately, if you're not measuring it, you're not going to get paid for it. And right now, there is this incredible emphasis on fraud, waste, and abuse in the Medicaid system. A lot more emphasis on fraud, waste, and abuse than there is fraud, waste, and abuse. But the best protection for fraud, waste, and abuse being used as a cudgel against you is to have the data at hand that demonstrates that you did it right, you did it well, and you produced the outcomes that the people you serve deserve. In conclusion, the data are critical to quality. The first and foremost reason to collect the data is because it enables you to take better care of the people that you serve, but they're also essential to getting paid. No money, no mission. And we as a community have to figure out how to standardize this, because if we don't figure out how to standardize it, somebody's going to standardize it for us. And the likelihood that they standardize it in a way that prioritizes the needs of the people you serve instead of prioritizing the dollars, I think is very low. And like I said, a journey of 1,000 metrics begins with a single step. So the key is to begin and just take the next step wherever you are. And with that, I will turn it back over and say thank you.
Thank you, Josh. We're now going to ask our LSA peer colleagues to join the conversation. And I want to welcome Crissie Anderson from LSS Illinois and Kate Hutchinson from Lutheran Social Services Northern California for this portion of the discussion. And I'm going to hand it over to Crissie, I believe, first.
Thank you. So I am from Lutheran Social Services of Illinois, as Sue mentioned, and we've been around for over 150 years. We currently serve about 37,000 primary clients across 3 main networks: behavioral health services, which encompasses both mental health and substance use; seniors and disability services, which covers our IDD population, home care, and some affordable senior housing units. And then we have a large child welfare division as well. We have well over 100 programs with 36-ish unique program offerings, and we have about 60 program sites across Illinois. So we're pretty large. And my area, which is quality, compliance, and data, we have the responsibility of overseeing a lot of the quality and the data for those main areas. We have a team of 6 FTEs, and we wear a lot of hats. So managing all the data, it can be challenging for us, and particularly behavioral health, which is our most challenging area. That is I think everything Josh said, I would agree with completely. And I've lived through my 15 plus years in the quality and outcomes data space. Those are the things we struggle with very much. We, as an organization, have 3 main, what we call mega outcomes, that we try to have all of our networks and our program service lines track and measure, and those are promoting dignity, enhancing health and well-being, and reaching full potential. Those are obviously mega, and they're very encompassing. And the challenge is to try to layer that on top of all the program outcomes that these programs are typically mandated to measure, or we have to come up with some additional measures. So it's a challenge to hit all of that and track and measure all of that. We are doing a lot of that work via a dashboard system. Now we're also in the process of looking for a new vendor for that system, because our 1.0 option, I guess you could say, hasn't proved that that robust of a system, and it's been challenging. So we're in the middle of looking for a new one. But what we have had and built out already has been successful. People are looking at it and using it, and it's been helpful in moving the needle around staff engaging with some data. But it's a big push for us, I think. And then again, in our behavioral health group, that's our most challenging for a lot of the reasons that Josh said. We have lots of data and lots of disparate systems. We have to report a lot of data to external groups. We don't always get the data back. And so we then are challenged with, or we're entering it, I should say, into their system, so we don't get the data back. So do we want to make them do double work? Oftentimes we don't. And so we either we go without that data, or we get it back in a report that's not, it's not something that we can then slice and dice in a way that's meaningful and valuable for us. Or we have data that we have to collect, but staff don't particularly seem to have any agreement or alignment with that. That doesn't seem to be helpful or valuable to them in the work they do, but the funder wants it. So we produce that data, and then we don't want to overburden staff with trying to do things that actually matter or have value to them. So we try to make, I don't know if it's making a square peg fit in a round hole, but we're trying to make the most of what we ask them to do, because their workloads are immense, and we don't want to make them do double work if we can help it. And then just tracking things. Again, I have 6 FTEs who do a lot more than just manage data, so we don't want to have them try to come up with and work on all of these random different metrics, trying to come up with things that work, try to be as efficient and kill multiple birds with the one stone. So those are the challenges that we face, is particularly in our behavioral health services. And I think that's where I'll end for now.
Thank you, Crissie. And I apologize. I'm having some Wi-Fi challenges today, so I apologize that I'm a little off and on here. Thank you for those great overview, Crissie of LSS Illinois. I'm going to turn it over to Kate now.
Hi. So going from the large to the smaller organization, LSS of Northern California has a very specific mission, and that's to provide housing and supportive services to people who are homeless. And of course, many of those people are also interfacing with the behavioral health care system. Though our mission is specific and our demographic is very specific, the range of services that we provide to accomplish the mission is enormous, which makes measurement of quality its own special challenge. For our agency, the ultimate outcome is housing retention. But in order to achieve that outcome, we're not just addressing behavioral health challenges, physical challenges. We're also working on budgeting, employment, education, transportation, childcare, the full range of things that people need in order to be stably housed. So a lot of our data collection is really proscribed by our funding sources. We're funded through HUD, county and state government, and our CalAIM program, which is California's fancy name for Medicare, Medicaid services. So for all of our programs, we've all reached an agreement, although we come from different areas, that we're going to enter our data into the Homeless Management Information System. And that provides us with outcome measures for things like number of people housed, number of people who stay housed, people who return to homelessness, improvement in income, connection to healthcare, and connection to other benefits. So it's kind of nice to have one system that all of our funding sources have agreed. This is how we're going to measure outcomes, and it makes it very
succinct for us. It's a major pillar of our outcomes. We don't stop there though, because as I mentioned, we have a lot of things that we're working on with our clients. So we're also using a measure called I think it's called the Arizona, I should look this up, the Arizona Matrix. It measures the social determinants of health. And it's a great tool if it's easy to Google and find it online. But they do a really good job of breaking down, I think, 18 social determinants of health that we can rank from 1 to 5, 1 being in crisis, 5 to being empowered. And it's a tool that case managers use with our participants, so they can self-evaluate where they stand. And we go through this with them every 6 months so they can mark their improvement, but it helps us also develop our plans for what we're going to work on with our clients. So I think that one of the important things about using the Arizona scale and really HMIS is that it involves the case managers who are doing the frontline work with our clients. They have bought into the value of the system and the data that it provides them. And so therefore we believe the data is accurate because it's like the measurement is only as good as the data that you put into it. So it's really important to have that buy-in from our team members. So that's an overview of what we do at LSS in Northern California and our measurement system.
Wonderful. Thanks, Josh and Crissie and Kate, for those great opening remarks. As we talked about making sense of behavioral health measurement, including in our policy committee, it's clear this is such a key area, right, for Lutheran Social Services members writ large because of the fact that behavioral health really cuts across all the populations that we serve, which you've spoken to, right? Family and children, older adults, people with disabilities. So I just wonder, since we have such a rich diversity of perspectives, as it relates to making sense of behavioral health measurement, what stands out to you as an essential needed next step?
I'll go ahead and
Well,
start.
I guess.
Oh, go ahead, Kate, please. No, Kate, please.
Well, I was just going to highlight what you said. We all need agreement about what we're measuring. I feel like that's the critical piece. Like, what an agreement between our funders and our staff teams. Like, what's important to measure and why.
Yeah, Kate, I agree with that 100%. I tend to think of this as sort of a Venn diagram, and what we're looking for is the place where the funders, the people who are being served, and their families, and the providers all agree this is important. And from the perspective of the provider, it can't just be important; it has to be important and something you can impact. Because at a certain point, and I am almost all of the performance measurement that we do is because some funder told us they want these data. And it's real easy to get caught in the like, I collected the data, I input the data, I'm done with the data, and miss the key next step, which is now I've got to build a process in my organization to use those data for continuous quality improvement. And that's the part that is A, the hardest, and B, the most expensive, and C, never paid for. But it's also the part that has the greatest payoff in terms of your ability to impact people's lives in a really positive way.
Yeah, I would agree with that. And after this article came out, we read it. My boss and I, we talked about what do we do next with this, and we're going to actually have our network executive directors review that measurement readiness phases and try to figure out where we're at, because that is the biggest challenge. Is now you have this data, how do you use it, how do you inform and make data driven decisions and feedback loop and all of those pieces, and it's not easy.
It's not easy, and it's going to get harder, right? At least in the short term, right? We have a lot of change afoot with Medicaid, the largest payer of behavioral health services. So, and again, sorry for the Wi-Fi disruption. And I want to invite our audience in on this conversation too. This is really meant to be, a conversation because we all have experiences we can bring to this, right? So I would just ask, maybe starting with the panel, Tell us about, why is this the right time to focus on strengthening quality measures amidst all this disruption, especially with Medicaid?
I think, well, I think it has always been really important, right? When we have the data and we can use them to improve people's lives, it's not okay to not do that. Right? Our mission is to improve people's lives. So we need to take advantage of that. That, in my mind, is about sort of offense, improving the quality of care. Given the current environment, I think we need the data for defense as well. We need the data to protect ourselves, to protect our funding, to protect our organizations. And so ultimately the fact that cuts are coming, right? The sort of Damocles is hanging over all of our heads. It falls on January 1st of 2027. We know that. The cuts are coming. The sort of the emphasis on fraud, waste, and abuse make it more and frankly the increased competition, including from some organizations that are backed by private equity, really need to have those data both for the purposes of moving our organizations forward and for the purposes of not allowing our organizations to be pushed backwards.
I would
Yeah,
add, go ahead, Kate.
I'll just say I would just add to that that data tells a story, and it's our opportunity to tell our story, and to we do segments with our staff and our board about mythbusters, things you may have heard, but like actually here's the data that shows that this is the accurate story.
And I was just going to add that I think we live in a culture now where data is everywhere in every industry, and people want data. So it has become an expectation to have to back up anything you're saying. As Kate was kind of saying about an example, even around MythBusters, it's everywhere, and so you can't really go anywhere and talk about what you're doing without being able to back it up with some statistic or some kind of outcome to back it up.
Yeah, Crissie and Kate, both of those I think are excellent points, and I want to quote one of my favorite professors in graduate school who always used to say, "Data is not the plural of anecdote." We have gotten really good at telling stories about a person that we served, but ultimately, what we need are those data that tell the story of our organization and the story of our impact. And so I could not possibly agree more.
Well, and I want to follow up a little bit. Josh, you touched on this, right? A little bit about emergency room intervention. But, I think with the release of our Partnering for Impact Guide earlier this year, which was right in part informed by OSA member case studies, including some of the folks with us today, there's a lot of intervention points, right? Given the diversity of the populations our members serve in behavioral health. Right, access points aren't always ideal, like the emergency rooms, there are school-based health clinics, all of this to say, what should we be doing right now? What seems urgent and necessary, as we think about this ongoing shifting landscape and these intervention points? What's really important for us all to be doing right now?
One of the things I think about a lot um, is about how to get upstream. One of the things that we are not that great at in this country that some of our friends in Europe, the social democracies of Europe, are much better at is taking care of people up front so they don't need the care later. Um, and decades ago, this incredibly important study was done about something called ACEs, adverse childhood experiences, and it really did point to the extent to which bad things that happen to you when you're a kid have long-term impacts on your health and well-being going forward. We've known for decades about ACEs. We don't track the ACEs of the people that we serve. We don't track the ACEs of the children we serve. And so to my mind, whatever we can do to get farther upstream is going to enable us to help people stay healthy instead of taking care of them after they get sick. And the more we can do that, the better off we as a system are going to be, but more importantly, the better off the people we serve are going to be.
I think really very practically too is making sure that our teams internally, and I'm a very internal facing area in my organization, that we are skilled to the best we can so that we can produce any of the things we need around technical skills. So a lot of my teammates are focusing in on learning Power BI or SQL, and really embracing we're in Microsoft shop, so we use Copilot and using as much AI as we can to get to the data. We're uploading our data now into Copilot and saying, hey, analyze this for us. We don't, let it do all hours of work and spit it out in 2 minutes. And then we can then take it and tell the story, and we can take it and bring it to wherever we need to go. And how it can serve us, but we don't spend the time on that because we're utilizing the tools that are available more effectively, so that our reach is that much longer.
So one of the things I'll say is looking at different systems that we interface with, emergency rooms, school-based health clinics, they all speak different languages and they all do different types of data collection. And so one of the things I talk with my team about is learn the language of the school-based system. It's way different than it is in the homeless system. It's how we all can communicate and reach agreement about what's important to measure.
Yeah, Kate, I think that's a really an important point. And one of the things I think about a lot is we have the healthcare system over here and we have social services systems over here. And in recent years, we have tried to figure out how to bring those together. Over and over again, what we find is they don't really speak the same language at all. And in my mind, you have a behavioral health provider community that has for some decades now had one foot in the healthcare camp and one foot in the human services camp and can serve as a sort of a Rosetta Stone. And so ultimately, the key to my mind is to coordinate, collaborate, cooperate, and integrate, because that's what's going to enable both the protection of the services that you all are offering, but also the utilization of those services in the most effective and impactful way by the service delivery system.
I think you're all just bringing forth such great, important, lines of sight across some of the, opportunities and challenges in this area. And I want to bring forth Mary Ring's question. I'm not sure you all can see this in the chat, but she's asking, we serve many different populations with different data points for outcome measures. For example, we have recidivism risk programs for justice-involved individuals. We have suicide prevention treatment. We have trauma treatment and sudden depression. We have case management for housing and employment. We use different measures for all of it. Are you saying we need one measure for it all? What would that look like? And Crissie, if I can put you on the spot, you talked about this way that you do this through a holistic sort of focus on dignity. You said dignity, well-being, and full potential. Could you just say a little bit more about that?
Sure. So again, these are the main ways that we would be measuring how effective we are at our strategic plan, and the main push we have within our organization around achieving those goals. And my team has been challenged with trying to figure out how to measure that for everybody. The last thing I would like to do is add an additional measure on top of all the other things that they already have to do. So for two of them, enhancing health and well-being and promoting dignity, we kind of took an easy path and just added questions on our satisfaction surveys. That's our approach right now. How much do how's your well-being? I forget exactly. Very simple questions on the survey. And the dignity was more complex because it is a more complex concept. So I think it's measured by 3 questions on there. And then our full potential, we layered on this scale of, we call it surviving to thriving, and it's 5 points. And we then use our existing outcomes that maybe they have 4 outcomes. They have to pick 3 or so that they think get at surviving to thriving. Get at full potential. And then we come up with a way to measure what is vulnerable. Like there's 5, it's a scale of 5 points, and what are the metrics that fit in all of those. And then we layer that on top of all the programs. We're still rolling it out. We have, like I said, 36 unique programs. So that means different metrics that we have to work with each group. It's a multi-year project just because it takes a long time to work with programs on that. We've rolled it out in foster care, intact family services, and I think our senior housing units that we have. And we're moving into our behavioral health, which is going to be the biggest challenge we have. And I think we're starting off with our substance use group, our substance use outpatient for that. So it's trying to figure out how do their metrics work toward whichever ones work towards full potential, and then what is surviving, what is vulnerable, what is in crisis, and then what's thriving. And the goal obviously would be to look at that, and then we can eventually roll it all up and say, here's where we're at collectively, and this is where this network is, and that it's a long-term game plan.
Yeah, Crissie, what you just described sounds fantastic, right? But also points to the challenge. And Mary, in my wildest fantasies, we don't get to one. But the reality is that behavioral health spans all of these areas, right? I always say behavioral health is only needed by people who have brains, which is pretty much all of us. And so, we're never going to get to one, but let's see how few we can get that still tell the kind of the story that is meaningful and impactful, and that enables us to course correct when something's going wrong for one of the people that we're working with.
Kate, is there anything you want to add?
No, I just think that I say ditto. I agree.
There's some additional comments in the chat, Michelle. I don't know if you want to come off of mute and share, but you're saying LSS of Wisconsin and Upper Michigan does something similar to LSS Illinois, and that we have 5 outcomes that all our programs and services roll up to. And then Mary, you added sounding the basic human goods like the Good Lives model. So I think that's helpful. And does anybody have any additional comments, including from our audience? There is another question. My colleague, Ashley, is asking about, how AI is coming to bear in all of our work. And she's asking about threats and opportunities. And I might just go a step further too. How are you even just approaching this in your various work and efforts?
Well, we use AI when we are assessing all of our programs in the homeless management information system. We'll come up with our data measures, run it through AI, and look at where we need to improve. It's a really easy, fast way to do that with calculations that can be, complicated and mathy. So AI helps us with that. I don't see it as I don't see the threat with that, but it's been a great opportunity.
I would agree. We've used it to take shortcuts. If you got to make a form, can you go make a form that I had to update a HIPAA thing. And so I said, hey, can you create a request for this? And that, complies with HIPAA, blah, blah, blah. Within a minute, less than a minute, it created something that would have taken a lot longer. Like I said, we'll take our data set, upload it into Copilot, have it do the analysis, tell us the trends, tell it where the items that we have to pay attention to. And then we'll look at that and work on that with the programs. It just saves a lot of time. we find it most valuable in areas where it would take a person a lot of time to do something that they don't have to think. You don't like the problem with AI from some people's perspective is it doesn't, like I've heard people, and I'm not trying to get philosophical, but it doesn't have a soul, right? So it's I view it as something that it can, things that you don't have to think, you don't need like a human's perspective, all of those pieces that people bring. It's brilliant at that. Let it do all the things, the busy work that we don't want to spend time and money on, wasting brain power. And then the things that you have to create, that that's, I think, is worthy of the human brain power and creativity.
Yeah, Crissie and Kate, I agree with you. And the siren song of it is alluring, right? The opportunity to sort of offload scut work is really tempting. In that context, I'll be the skunk at the garden party. AI requires really rigorous governance. These are sensitive data. These are decisions that impact people's lives in substantial ways. And to your point, Crissie, we figured out how to build artificial intelligence. We haven't figured out how to build artificial wisdom yet. And wisdom is essential to making good decisions. And so there is a governance risk that I think is, we need to focus in on because it's not getting enough attention. The reality of AI is that it was trained on the internet. Anybody who's ever been on the internet knows it's a cesspool. The level of bias and sort of historic bleh that is baked into our AI systems is profound, and we need to be aware of that and attuned to the potential implications of that once you get sort of 3 steps removed from the bias, and so the bias is hidden. Importantly, and this is one of the things that I think about with AI a lot, there's all of this temptation to use it at the point of care, right? A therapist doesn't want to have to write notes. I get that. At the point of care, if something goes really wrong, that's a person who you might lose. If you're using it to like QA your bills and something goes wrong, you might lose some money. Now, I don't like losing money, but I'd rather lose money than a person. And so those are the sorts of, and look, I use it too, right? Like I'm not a Luddite saying don't do it. I'm just saying make sure that we're governing it right and that we're aware of where the shortcomings are and that we're ethical, because the AI, to your point, Crissie, AI doesn't have ethics. It has no moral compass. That's on us. We have to provide that even when it sort of feels like we can offload.
This has been a really wonderful discussion. I'm gonna pivot here a little because I don't think we have any other questions from the audience. But I want to just ask you as we kind of come to the conclusion of the webinar. If there could be one thing, right, a member organization that's listening to this conversation that you could impart about something you've learned over your journey in this area, of measuring behavioral health over the past year, something maybe you didn't know a year ago that you know now. What is that and why is it important?
I want to pick up on what Crissie said a little bit ago, right? That take the step back and sort of like figure out if here is 0 and here is where you want to be, where I'm sorry, I'm trying to do that on the screen. Where on that path are you? And really identifying that clear-eyed. And then based on where you are, what's the right next step, right? Not how do we get all the way to the end, but like what's the right next step? How do we marginally improve? How do we make one minor change that gets us in the right direction? Do that enough times, eventually you get to where you're trying to get to.
Cater, Crissie? And I can see you guys are thinking, so no pressure.
Well, just going back to learning the languages of other systems, I think that's probably been the biggest breakthrough in our organization because we work with a lot of different systems, the mental health system, the school system, the health system. So really understanding how they see the world has been really important to us in being able to provide services that our funders want to buy.
I think for us, I don't know, this is something we've learned is more we're now going to be forcing to do it, and I think I alluded to it, is finding what the staff value and having that, or within what we're required to measure, try to find it, have meaning and value for them, because your data is only as good as what you have. And if they're not measuring it, if they just see it as this thing I got to do to check the box and it has no value, it's not quality. It's not quality data. There's gonna be holes in it. It's not gonna be accurate. And then you're not gonna have the results you need, even if you're doing really, really good work. So I think focusing in on that would be where I think where we'll go.
Well, this has been a really rich conversation. And any final thoughts or closing comments that any of you want to make?
Just don't let the perfect be the enemy of the good. Please.
That's a great one. Yes. Kate or Crissie, any closing comment? No pressure.
I agree with don't let the enemy perfect be the enemy. Yeah.
Well, and thank you for listening.
Yeah.
No, I think we want to continue this conversation, and with Alicia's leadership, we're going to be continuing to try to build on this over the next year. And so, please, if you are listening in today, if there is a question you didn't ask, this is a generous group of people. I can assure you, folks that have shared a lot of their time and effort. So I'm going to turn it over to Sarah now for our final poll.
And I also wanted to pop this up because I know people we're winding down our time, but we want to give everyone a chance to share how helpful we hope today's webinar was in their understanding of behavioral health measurement tools and how to use them. And certainly to thank all of our great speakers for being with us today. I think this was a really good conversation. I certainly learned a lot, or got a little better understanding of just kind of how this is rolling out and impacting our member network. And as I let this percolate, I just want to share, as usual, we will be emailing out follow-up materials to everyone, the slides, some of the materials we referenced, our internal papers, our Here We Stand resources, and as well as information about the upcoming webinars in our series. And of course, we always invite you to join us on community in our advocacy leads group. We'll share that link in our follow-up information as well, or wherever it makes sense for you to participate with us. Community is in our online engagement platform, and we love to have as many people as possible joining us there. I'll give folks a couple more seconds to reply, and then I'll share what we've learned. All right, I think that's it. Wow. So we had anyone who was at very low or limited understanding has moved up. And we've got everyone in at least moderate understanding up to strong and very strong. So I think that's great. I think I'm really happy that everyone could be with us today and could get good information from our webinar. So thank you so much. And we look forward to having you with us at our next webinar.